My name is Dr. Tracye J. I am coming from Boise, Idaho. I'm really excited to share the technique for this allograft OATS procedure. This is a resurfacing technique for articular cartilage restoration. And we have a right knee in front of us. So after we scope, everything looks good in the joint. I've made this incision a lot bigger than I would normally, but I want visualization to be great for you all. So usually I'm using kind of a medial parapatellar. So just to orient you here, patella along here, and then I'll use a medial parapatellar arthrotomy when I get into the joint. I leave a little leaflet so that I can close it along the patella. So that's really important. And so what the hardest part about the exposure is really getting the patella kind of out of the way. And so how do we do that? Usually what I'll do is I like to resect some of that fat pad just posterior to the patellar tendon. So I've resected all this fat pad that's posterior to the patella tendon, but anterior to the actual ACL. And then I really want to make sure I'm very careful of not to damage the meniscus, the medial meniscus in this case. What helps me to really pull this over is I usually use a Homan. And so I'll take any kind of Homan and I'll basically put that Homan right behind the PCL. And then I can kind of just pull that over. And then I start to get good peak of that medial femoral condyle. And now what do you kind of do with here, the skin and the capsule is I'll take a Z retractor and then I will place that kind of right into the gutter. And so I'm right behind the MCL. And so now, even with those two retractors, and I can usually have maybe even one assist help me out, I'm able to get great exposure of this medial femoral condyle. And so what we do is we're going to do everything on the patient right now. And I'll show you the steps that I use to mark out the defect. We didn't have a defect, but actually this patient has a little bit of a grade 3 to 4 chondrosis. So I'm kind of excited. So we go ahead and start with the sizer that we need to use. Really important with this sizer, if you're able to see, there's a little notch kind of across here. So there's a bigger side and then there's a smaller side. That smaller side is going to actually go on the patient, and this larger side will actually go through that bushing in order to harvest the graft. So again, I'm going to be focusing just on this side and place this flush against my condyle. You obviously want to make sure there's good coverage of your defect. There's different sizes. This one seems to cover that defect really, really nicely. I want to make sure that this is what we call a contained lesion. So contained meaning I want to be able to have a rim of cartilage on either side of this. That allows for great press fit fixation, and I don't have to use anything additional in order to fixate this graft. So you don't want to be too far off. You want to cover the main weight-bearing part of this. What I'll do is once I feel like this is covering a good portion of that, I'll take a marking pen, just one that just kind of comes in the set, and I'll basically kind of mark around this graft. But I'm kind of getting a good idea. And when I take that off, I at least know when I come back, I'm going to be at least around there. So I kind of mark that. So the next step that we're going to do is put a guide wire through the actual sizer. And you can see there's a hole right in the center, and that's where that guide wire is going to go. Again, I'm going to line everything up. And so sometimes what I'll do is I'll put the wire in and then I will come off the sizer. And I just want to make sure it's sitting flush. But I feel like it's a little bit off on the medial side of the medial femoral condyle. Now when I kind of put it down, I feel like it's hitting all points. And then what I'll do is I'll just ream this a little bit just to get some fixation and pull that out. And then what I'll do is push that back and forth just to make sure it's looking good and all areas are touching. So I think that looks really good. I think we hit the major weight-bearing spot on our medial femoral condyle. So once we have that sizer and everything looks nice and flush, we'll remove that sizer from our guide wire that's basically central in our defect. We're going to go ahead and use the score. Along with my marking pen, this allows you to make a little bit of a kind of rent in the cartilage. So this allows you to kind of see exactly where you're going to be taking out that bone or that bad pathology. And so you'll be able to slide this on. And again, you can see how it's hitting nice and flush. And then usually I'll take a mallet and I'll just kind of lightly just give me a little score on there. And we can kind of see how it fits right into my score nicely. And then I'll pull that off. Guide wire stays in. So now we want to make sure that we orient when we put this graft in. And so I'll mark a 12 o'clock position. You can even mark a 3 o'clock position, 6 o'clock, and 9 o'clock. What I normally do on the back table is I'll just take a card and I'll just have this card and then put kind of a clock face on there. And so this would be my 12 o'clock and then just kind of going around. And so what this does is it helps me get my depth, because I'm going to ream a depth of about 10 millimeters, but sometimes it's not perfect, where maybe here it's 9 millimeters, here it's 10 millimeters. And I want to make sure that these markings all match up to my graft, because we want this in nice and flush. So now we'll go ahead and we'll do the reamer. So this is the reamer with the positive stop. What you can see, we've kind of checked this on the drill, but this is the amount that I'm going to ream to. And if you can look at that. And so there's a 10 right there. And so that's what I'm going to ream to. And this little locking knot in the back here allows me to stop. So I know I'm going to get good feedback at a good positive stop, and I know it's going to be at 10 millimeters. So I'll go ahead and put that over the guide wire. What I'll do is I'll start it off the bone here, and then I'll start to tape. And so I like to not, go all the way down. So I just like to see and make sure I'm making that really perfect circle there. And so that looks really, really good. So it always jumps a little bit as you go through the cartilage, and now you're going to get to the cancellus. So you got to make sure that you're not plunging, but the positive stop is kind of your backup. So I'll just continue down with that, just nice and slow pressure. And now I'm at a positive stop right there. I can't go any farther. And then I'll come off. And that looks like a very, very good spot that we maybe have good bone on the bottom of this defect. And then what I'll end up doing is cleaning off all these shavings as well to make it nice and clean. So again, after you've reamed, you really want to make sure that you clean up all those cartilage and bone shavings along there. Irrigate this at this point really, really well. And then I will take the measuring device. So you can see those little notches on this measuring guide. And so what I'll do is I'll put this actually in the defect, and then I'll start to make my points in that clock fashion. So now we know that we reamed out a 10, but we just want to make sure that we got this correct. So what I'll do is I'll put this in here along here, and then I will kind of read out to whoever's working with me and read out those markings. So at the 12 o'clock position, we are looking at probably 11 right now. My 3 o'clock position is going to be a 10. My 6 o'clock position, probably 11 at that point. And then my 9 o'clock position is about 11. So that just kind of gives me a good idea of what I'm working with. So you don't want to jump to the graft and just start nibbling away bone. You want to make sure that all these points here are flush. You're not going to get it perfect, but you don't want it to be proud. Sometimes if I need to, I'll make it a little bit recessed. If I'm measuring right now, probably a 10 to 11, I obviously don't want to make my graft a 12 because I know it's going to be sitting high up. And so we know that there's going to be an increased risk of graft failure with that. So I might go a little bit lower and only actually nibble away a 10 or even a 9 sometimes on my graft. So there's a lot of kind of finicky stuff going on with this, but you want to make sure this is nice and flush. And if you want maybe a ½ centimeter recessed. So sometimes when you're looking at this bed, sometimes you'll have very sclerotic type bone. And I'll take like a 2-0 drill bit. And what I'll do is I'll drill holes into that bone along there. Sometimes I'll have to take out the guide wire. Sometimes I can do it without. And then I'll place some DBM as well in that bed. So just in case, most of the time, if it's good, healthy bone on the bottom of that bed, then we just kind of leave it and just go to the graft. So now we are on the back table with the graft. So we're going to harvest the graft. Looking at this workstation, I've used the spacer blocks, kind of raised up the graft a little bit. And that way I can see the contour of the graft on all angles. If I didn't have the spacer blocks and these were out of the way, then the graft would be down and then I might lose maybe some of the contour that I'm missing. So now I can really, really see the contour of the graft and match it to our donor site. I've elected to use this straight plate to kind of compress that graft so it's nice and sturdy. And then I've used this cheater bar and placed it to really tighten and cinch down that graft. It just Makes me breathe a little bit better, knowing that my graft's not going to move everywhere while I'm reaming that out. I have my card available. This is what the depth that I have written from the graft, so I kind of get an idea, because when I take out the graft, I'm going to use those markings. I'm probably looking about a 10 millimeter, although I'm going to take to about a 20 millimeter on this graft. I have this sizer that we've been using on the patient, and I'll use this sizer. Again, we're looking kind of at the, what I call the fatter end. So this side is what we used on the donor, on the patient, and this side is what we use on the graft because it goes through nicely into that bushing. So that's what we want to have. And again, I get confused with this all the time, but just the bigger side will go on this. And so as you can tell, kind of made it so it's very, very flush now to the graft. So as I raise up and kind of push, as I slide along, there's really no points that are not touching the graft, and that's what I want. I am using a lateral femoral condyle that I am going to put into a medial femoral condyle defect. But again, you can, as long as you find, and you can move this anywhere to find that flush point on the graft, it's really, really important. And then this is going to be basically the reamer that I'm going to take the graft from along here. I'm going to take a lot bigger than that 10 millimeter, so then I can fashion the graft. And this clamp along here is nice, is that when we get the graft, we can clamp it. You want to clamp it around the bone. And then you could take a saw and start to cut down that extra bone that we don't need along there. What I'll do is I'll take my guide. It looks really, really good. So the next step we're going to be doing is reaming this graft, using this reamer, placing it through the bushing, kind of where I put my sizer. Usually I'll have my assistant putting down some saline as I ream. So go ahead and slide it down here. Usually try to start off the bone. Okay. And then we'll take it off and we'll clean off the graft. So now I'm going to come in with a saw blade at the side here. Usually turn it upside down, and it can go nice and flush to the straight plates. And I just kind of rest it along here. This depth, this is also why I raise it up and use the spacer blockers along here, is this brings up that graft for me, and I'm taking probably about 20 millimeters. And so then I'll be able to fashion the graft and cut it how I want to in order to fit into the defect. So I usually go ahead and do a little saline once again. All right, so now I'm going to remove the boom arm and the bushing. Now we just have our graft. And so it's really important that you cut all the way through, because it allows you to get that graft out nice and easily. So I can just kind of put my thumb underneath here and then almost just pull that graft out. So now we have our graft. This part of the procedure is where I take the most time to be able to fashion this graft so that I can fit it into our defect nice and flush. So you could say this is just kind of our raw cut of the graft, and you can kind of see how it's sloped. So I'm looking at, how much bone along here. But then it's really, really important to look at the actual cartilage layer along here. And so there's certain areas where the cartilage is a little bit thicker. And so it's really kind of picky, but it's really important to be able to examine this graft and make sure that you're putting that really good kind of thicker cartilage along the weight-bearing region. And if you remembered, we marked on the patient where the 12 o'clock position is. For me, the 12 o'clock position on top of the graft is going to be right where that thick part is along here. So that's kind of what we're looking at, the 12 o'clock. That orients me when I'm putting in the plug into the defect. So now I want to look at the depth, and I've already kind of made these markings, but I'll take just the standard ruler that comes into any kind of set. I know that from my markings along here, the 12 o'clock position was about 11 millimeters. And I kind of went around the 9 o'clock and 6 o'clock position were at 11 millimeters, and the 3 o'clock was about 10 millimeters. I want to make sure that this is not proud, so I definitely don't want to go 12 millimeters. I'd rather go on the lower end, and so I'm going to mark it around 10 meters all the way around. So now I have my ruler here. What I'll do is either I will or my assistant, I'll go all the way around and mark this, because that's where I'm going to cut the bone and cut the graft. So then what I'll do is I'll take this clamp, which is really nice, where I can open it up. And those teeth, I want to make sure aren't touching the articular surface, but they're on the bone. And I'll clamp that down and clamp it around the graft and tighten it down. Then I'll turn it upside down, and then I will saw where my markings were. So taking the graft, putting it upside down, putting my teeth in. Again, I want to make sure that I'm not really squeezing on that articular surface here. And it doesn't have to be perfect. So I'm going to saw down majority of this bone, but usually I'm using a rasp or a rongeur to make those fine adjustments. So I'll go ahead and tighten this down really nice and tight. So now it's really tight. So we prepared the graft, cut it, and then I've kind of fashioned the graft, meaning I've used maybe a rongeur saw to kind of really smooth out the edges along the graft. It's really important to pulse lavage that graft. I usually use about 2,500 cc's of saline at least. You can use a full bag of, 5,000 if you wanted to, but I usually use saline to pulse lavage that. That's the really important part. So I turn it upside down and pulse lavage the bone. So after I pulse lavage the graft, I'll either soak the graft in ACP or I'll drip some on the back part of the bone along here and let that sit while I go to the patient and go ahead and prep the bed of the defect once again. All right, so we're back at the patient right now, and we've got our guide wire in. And what we want to do now is dilate this. So here's the dilator. It does have little notches, but this makes it nice and smooth. And so what you can do is place this dilator over your guide pin. And you can set it in there nicely. And then I'm just going to mallet this. You can either mallet it or it has a hand one that you can kind of pound in along there. So either or. And you're just kind of making sure you're getting down to that 10 mark. Then I will pull out that guide wire. So we're ready to put the graft in. I kind of wanted to show a little bit of trick that's nice so you don't feel like you've bought this placement of the graft because you're going to be tamping it in. So normally what I do is I'll just take a suture, and it can be any suture that you want, and I lay it in the bed along our defect, and I can kind of push in on either side, just kind of make sure it's in the middle there. And now I can take my graft. Again, we're looking at our orientation. So our orientation with that mark is going to match this orientation that I had up on top. And so what I'm going to do is start this graft, keeping that suture there and keeping the orientation. And so what's nice with this suture is, say I start cinching it down a little bit and I really don't like the way that it's going, it might be turned or whatnot, I can just pull kind of on that suture and it will pop out, and then I can start all over. And then at the end, we can just cut the suture and pull that out once you have the graft seated in there. So again, I'm going to put that suture and lay it in that bed. And I push in just a little bit of pressure just to get either side just kind of started. And so I'll take my tamp, and I'm being very, very gentle with pushing on this. Again, these are live chondrocytes, so I don't really want to hit hard, but I'm going very gentle, and I'm checking at each point to make sure the graft is going down the correct orientation. So I'll mallet it just very lightly, and then I'll double check on all sides to make sure that it's going down the way I want it to go down. And I might have to move it on either side of the graft if I feel that maybe one side is going down a little bit better than the other. And so I'll keep going. And that's looking pretty good to me. Again, very light taps. And keep going along there. And then going across there. So to me, that's a pretty good flush. I didn't hit it too hard. And then I kind of feeling along with my finger just to make sure it's nice and smooth. And then with the suture that's under there, you can just cut kind of one limb here. And usually I still will kind of hold on. Perfect. And then you can pull that out. And sometimes I'll take that tamp back and kind of give it just a little bit more taps and make sure it's seated nicely. And then normally what I do, I'm still rubbing across here, make sure it's nice and smooth. And then I'll take out my retractors here, and then I'll range that knee and make sure that it's not catching on anything. And so we got a nice press fit along that medial femoral condyle.